welcome everyone. I am Rachel. I am community manager here at Alloy Women's Health. We are a digital health platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. Today, once again, I am so pleased to welcome back to the platform Dr. Mary Claire Haver. Dr. Haver is a board-certified OBGYN who graduated from Louisiana State University Medical Center and completed her residency at the University of Texas Medical Branch. I saw that. She's also a Certified Culinary Medicine Specialist and a Menopause Society Certified Menopause Practitioner. With millions of followers across social media platforms, Dr. Haver is recognized as a thought leader and author who provides valuable advice for women going through different stages of menopause. She aims to demystify menopause and promote self-advocacy for women's health. She is the author of the acclaimed Galveston Diet and the New York Times bestseller, The New Menopause. Dr. Haver is also the founder and director of the Mary Claire Wellness Clinic in Galveston, Texas. Before we get started, I just want to remind you, or I'm sorry, invite you to take advantage of today's code HAVER20 and enjoy $20 off at purchase on myalloy.com. Also, as a reminder, I will be turning to your questions during this conversation, so please do drop them into the Q&A. But just be mindful that Dr. Haver can't speak to specifics. She can speak in general terms. Dr. Haver, before we get into the nitty-gritty today, so happy to see you again. It's always a pleasure. I'd love to just kind of take a step back. You are so on the fore, and I'd love to just kind of get feedback on this career that you've built, helping women navigate menopause and sort of understand your deeper why. Was there a personal experience or defining moment that led you to focus on this field?
I just feel like I'm living proof of happy accidents. There was no intention. If you would have told me 10 years ago in 2016 that I would be where I am today, doing what I'm doing today, having a social media following at all, I would have said you were absolutely nuts.
Yeah.
My husband worked overseas. I was a single mom 6 months a year because of his job, something we signed up for. My kids I was still mothering, full time, and a full time academic OBGYN. And things started turning for me, the thought process around menopause. I would have told you back then also that I was a great menopause provider. And now that I can honestly look back and tell you I was terrible, I was the full on work out more, eat less. I knew nothing about the withdrawal of estrogen doing anything other than hot flashes and taking a hit on your bone density and maybe some vaginal, genital urinary symptoms. But outside of that, there was no teaching. I didn't really understand perimenopause. And so when I was going through it, I was terrified of hormone therapy because of the WHI study. Sadly, my boards, which I took every year to recertify with the American Board of OBGYN, didn't include hardly anything on menopause. Lots of great stuff I had to recertify in, babies and deliveries. And I'm not knocking what I learned, which was important, but women's health outside of reproduction is not prioritized. And sadly, which is embarrassing for me to admit, it took me going through it and realizing there's no quarterback for us. No one is putting the pieces together. And for me, also embarrassingly, it started with weight gain. So I wasn't thinking about my bone density or my frailty risk or ending up in a nursing home and all the things I can do to avoid that. I was thinking about, I was frustrated with weight gain and really cosmetic weight gain. I wasn't unhealthy, and I had been privileged for most of my life and I'd lost that. And, the whole evolution of me doing a deeper dive into nutrition and lowering inflammation through nutrition and how the loss of estrogen is leading to increasing inflammation, and just my whole world exploded into this is way bigger than some uncomfortable waistband on my pants. This is about where's the people taking care of us? And why are we so afraid of hormone therapy? And I went to my first menopause conference and heard Avram Blooming and Carol Tavris and Sharon Malone, from Alloy speak. And I was crying in the audience because no one had ever put that information in front of me, that most of the findings of the WHI about the safety and efficacy, safety of hormone therapy have been walked back. And actually it was safe for the vast majority of patients. I was so reluctantly prescribing hormone therapy with, so much fear that I was going to hurt the patients. And, it's just been a revolution in my head on, we are underserving ourselves at this age, and the medical system was not built to take care of us. And, so grateful for Alloy's work, Midi's work, Evernow's work, these platforms that are being developed specifically to take care of us at this age and to provide a conversation at least around, a woman making an informed choice for herself. So I got 1 hour of menopause in medical school in my 4-year curriculum. Okay. And then in my OBGYN 4 years of training, I learned incredible important stuff that I am so grateful for. But I maybe got 6 hours of menopause. And it really wasn't clinically significant. Not really. So, 10 years ago, I would have said, I'm a great menopause provider. I passed all my tests. I blew the top off my boards. I recertify every year. I know what I need to know. I hadn't even scratched the surface, and it took me being self-taught, getting books, searching out other experts in menopause, joining the Menopause Society, going through their curriculum, for me to realize we're not doing this right. There's so much more we can do. And I'm going to start talking about it on social media on a whim and see what happens.
Yeah.
So
and you did, and the rest is history.
Right. And
so
in 2021, I took a huge leap of faith and said, I'm going to walk out of the hospital and leave the babies to someone else. And I'm going to open a menopause clinic. And I don't know if it's going to be successful, but I got to try this.
Mm-hmm.
And here we are.
And here we are. So you raised a lot of issues, sort of lack of training, social constructs, the benefit of hormones, the results of the WHI study. I was at an event last night, and you are talking about perimenopause and menopause every day. I am talking about perimenopause and menopause every day, but it was not lost on me that in one evening, a gathering of women came together, and many of them were hearing things they had never heard before. And they had sort of stepped into this conversation for the very first time. So if you would just take a few minutes and explain to us the basics. What is perimenopause, menopause, when does it start, and so on?
Sure. So let's talk about why females go through menopause. That's not something I've fully understood or I thought real hard about. I just knew it was something that happened, right? So it turns out females are born with all of our eggs. Males make the eggs are germ cells in medical terms, and the male germ cells are the spermatids, right? In the male milieu. They make their stuff fresh every day from puberty until death. Okay. It gets a little harder as they get older, but they can still do it, right? Females, we are born with our stocked pond of eggs. And the maximum amount of eggs we have is actually 5 months inside of our mother's wombs when we're still developing, right? And then the eggs start to go through a process called atresia, which we don't understand very well. From the moment those first eggs are formed. So by the time we're born, we're already down to 1 to 2 million eggs on average. By the time we're 30, we're down to about 10% of our egg supply. And by the time we're 40, we're down to 3%. Menopause represents no more eggs. And when we run out of eggs, we cannot produce around the eggs. There's something called granulosa cells and pink lutein cells, which produce our sex hormones in the form of estradiol and progesterone, and about half of our testosterone. So perimenopause begins when we reach a critical threshold in our egg supply where the signals, so why do we ovulate each month? So most women have seen the hormone monthly curve where we have a spike of estrogen mid-cycle and then progesterone kind of rises after. And the stimulating hormones coming from the brain have rise and falls as well. And for a healthy woman, we get this very EKG-like, predictable, repeatable cycle month after month after month after month, unless we're pregnant or have some metabolic, issue going on that disrupts that. Okay. Or on birth control or something. So perimenopause is when we reach the egg level, the quality and the number of eggs is so low that the stimulating signals coming from the brain stop working as well. And so the brain is like getting aggravated. Where's my estrogen? I need more estrogen. So it's sending out bigger, harder, faster signals, almost like the TSH rising in hypothyroidism. Exactly the same thing happens until it forces that ovulation. And so then the progesterone never kind of gets to where it was before, like in the premenopausal years. And that so the average age of like the end of the eggs is about age 50 to 51 in the US. It's different for different genetics, for different areas of the world, a lot feeds into it. So but here in the US, it's about 51. Peri begins typically 7 to 10 years before that. So normal menopause is still, women go through at different ages. So 45 to 55 is under the normal curve. And let's back that up 7 to 10 years. So, for perimenopause, so it's completely reasonable for a 35-year-old woman to have symptoms related to the loss and decline of her estrogen or the fluctuations that are happening in perimenopause.
Thank you for that. I so appreciate that. And thank you for sort of reminding us that this can begin in our mid to late 30s. It is absolutely normal. And women so often look back and think, my gosh, I think that was probably my first symptom. And
yeah. And so a lot of retrospective, like,
yes.
what I learned when I was researching for the new menopause, which by the way, just hit New York Times bestseller 23 weeks in a row. So we're like,
congratulations. That's
for
awesome.
A woman on that list, it's hard.
Yeah.
And for a book about menopause,
yeah. It's
so anyway, sorry, shameless plug.
No.
There are estrogen receptors and testosterone and progesterone in almost every organ system of our body. Our brains, our bones, our muscles, our heart, our kidneys, our lungs. And when estrogen declines, function changes. Estrogen is a powerful anti-inflammatory hormone in almost every part of our body. And we lose that protection as we start going through menopause. It's protective in the brain. So in perimenopause, we see about a 40% increase in mental health disorders. We see the brain fog, which is lost. Our cognitive abilities begin to go on, get wacky. And for some women, it's the beginning of their path to dementia.
Yeah. Yep. Thank you for that. Can you run through a little bit more about symptoms sort of known, right? Most women will agree, hot flashes, heard of that, know about.
Right. I mean, and that, most of the research in menopause, sadly, has been centered around hot flashes, vasomotor symptoms. And for decades, it was all that was recognized as menopause. No one realized that their insulin resistance goes up, that our visceral fat deposition goes from 7% in a premenopausal woman of total body fat to 23% in a postmenopausal woman, just from going through menopause and no changes in diet and exercise.
Yeah.
Insulin resistance goes up, blood pressure goes up, weight goes up regardless of menopause. That just, we got to figure that out. Body composition changes. We are losing muscle at accelerated rates. We start losing bone in accelerated rates in perimenopause. So this is kind of all new to, and a lot of doctors were never taught this. And so you walk in, you only have about a 7% chance walking into your OBGYN or primary care doctor to be able to have an educated conversation about your own menopause. And that's not that clinician's fault. Right. That is a fault of the system who has marginalized women's health across the board, but especially after reproduction.
Yeah, thank you. Thank you, Dr. Haber. So today's focus is really about personalized approaches to care. And when it comes to menopause, there's no one-size-fits-all solution. How do you approach personalizing treatment for each woman? And I am thinking also about sort of the impact of MHT in that conversation.
Yeah. So I always lead off with, what do we know that we have things that menopause hormone therapy is approved for? Okay. It is approved for by the Food and Drug Administration for treatment of severe vasomotor symptoms. Okay. So hot flashes, night sweats, and palpitations actually are now recognized as part of vasomotor symptoms. It is approved for prevention and treatment of osteoporosis. Okay. It is approved for a patient who has premature ovarian insufficiency, and it's much higher doses than MHT. We need to get them to their premenopausal levels, not their post, and MHT is much lower than what we would get in our premenopausal years. And so, but there are things that we know that when we look at observational studies and population studies, that women on MHT have a lower all-cause mortality versus those who aren't. So these are the things I'll discuss with my patients. Like, what do we know? What is it approved for? Okay. What do we know it might do for you? No guarantees,
Right.
And we have to look at her age. So we know that women who start hormone therapy close to their menopause within the first 10 years or before the age of 60 could have a cardiovascular benefit. On average, women on MHT have lower cardiovascular disease in the form of atherosclerotic plaques and heart attacks and death from heart attacks than women who are not offered it. So there seems to be something protective there, especially, in that younger population. So I'm going to discuss those things with her. We talk about her symptoms. We look at her age. We look at her family history. We look at her, potential risks and benefits for her. And then we begin a discussion. Is this something she's interested in? Would she like to begin a discussion on hormone therapy? So I always start in my clinic with estradiol. That is kind of what's been the most studied, where we know most of the benefits is not allowing your body to be away from estradiol. What could that potentially do for you? It's always going to protect your bones. Early in the course of your menopause, it's likely to be protective for cardiovascular disease and maybe, decrease. So that's the number one thing women die from, is
Right.
cardiovascular disease. So we have a serious discussion around that. We, talk about her symptoms, her libido, her, sexual function, her vaginal dryness, her, what do we know? Maybe topical or local estrogen would be helpful for her if she has genital urinary syndrome, vaginal atrophy, pain with intercourse. We go through all of that. If she has low libido, and we in my clinic we do a very aggressive sexual function screening, and
Mm.
so does she have a good relationship? Is she having pain? Is this an arousal disorder? Can she orgasm? Did she used to have a good libido with this partner and something has changed? This is how we determine who's a good candidate to consider either testosterone, which the Menopause Society has said is a good idea, a good option, or one of the other FDA approved medications. Testosterone is not FDA approved for this,
Right.
right? We use it off label, but there are two, Addyi and Vyleesi. So we talk about those medications and how those may be helpful. In my clinic, I have a body scanner. I'm looking at visceral fat, muscle mass, pre-diabetes. I'm doing extensive screening. And there are patients who are good candidates for GLP-1s,
Mhm.
who are pre-diabetic. We talk about metformin versus GLP-1s and side effects and stuff. So, menopause care. And then, that's just the pharmacology stuff. Okay.
Right.
We talk about non-hormonal options, Veoza, and different medications that we use just for hot flashes. She may not want hormone therapy, or she
Mm.
may not be a candidate because of a contraindication. We go through the other medications that may be helpful, but we have to break it up into symptoms, right?
Yeah.
And so if she's got osteopenia, osteoporosis, what do we know would be helpful for that? In my clinic, again, I have an hour with my patients. We do a lot of nutrition counseling. We are talking about processed foods. We are talking about anti-inflammatory nutrition. We are giving them meal plans. And I have a background in nutrition, so I'm able to do that for them. We talk about exercise. Most of my patients are at least walking. I try to
Mm.
meet them where they are. If they're sedentary, I'm like, can you give me 30 minutes, 5 days a week for walking? We can cut your risk of type 2 diabetes by doing 30-minute walks after dinner every day. Um, And if they're already walking, I encourage them to get a weighted vest. We talk about resistance training, adding in resistance training as they become healthier, how important it is to keep your bones and muscles strong. We talk about supplements. I encourage them to download a free nutrition tracker. We're looking at fiber intake, vitamin D, magnesium. Are they meeting the FDA minimum for that? We give them very aggressive protein goals, given protein is so protective of our bones and muscles, and most women are not getting adequate protein for that amount. So, that's when I talk about personalization, we're doing the whole toolkit. Pharmacology, supplements, nutrition, exercise. We talk about stress reduction. We talk about sleep optimization, getting the room cool enough, getting good sheets, getting a good pillow, all the things we need to guarantee. Cutting back on alcohol or doing away with it altogether seems to be the best thing for sleep.
For
So
sure.
for those who struggle with it.
I love that in the truest sense of the word, a holistic approach to women's health. And I do encourage you to speak to a menopause practitioner like we have at Alloy, a deep bench of physicians who've gotten that extra training, who can speak to you about the immediate benefits of MHT, whatever else you have going on, and sort of the long-term benefits. It's, I think, an attention to women's health overall that we're not seeing in every other specialty yet, but we're getting there. Dr. Haber, I want to turn for a minute to questions that have come in. You have many. Here's the first one. Does compounded progesterone, is compounded progesterone safe to use if prescribed by my primary?
So I've dug into the literature on this, and I think it's ACOG and Menopause Society both are very wary of compounded progesterone. One, remember that I use compounding for different things. I love having options, but it is not my go-to, and I don't compound progesterone cream. Progesterone is a very large molecule, and it's very difficult to get it through the skin. It is micronized orally in the form of prometrium or oral micronized progesterone, for that form. But there is a big worry in the medical societies that the compounding progesterone is not going to be able to get your level high enough to protect the lining of the uterus, and that you will be at risk for endometrial hyperplasia when you're taking estrogen at the same time. So I don't recommend it. Every compounding pharmacy is different. They're not regulated by the FDA, which means for most of these pharmacies, no one's going in and testing the batches to make sure exactly what they say is in it. So when there was a study done that looked at the top 12 hormone compounding pharmacies, I'm not going to name them, and they found about I think it was a 40% discrepancy of quality control, whereas FDA approves, has a 2% discrepancy. So that's the kind of differences we're talking about. This is a safety issue. So for that reason, I do not recommend compounding your progesterone. We just don't seem to be able to get enough penetrated through the skin to get the levels high enough to protect the endometrium.
Okay, thank you for that. Another question, what do you do when severe GSM not healing after 1 year of vaginal testosterone and vaginal estradiol?
So make sure it really is GSM. You need to see a gynecologist who specializes in the vulvar vaginal area. So Jill Kraft is a fabulous person to follow on social media for this. Again, lack of training in gynecology in the menopausal patient has kind of led to some of these problems. And so what you will thought of as GSM may be something else, like lichen sclerosis or another, like some type of an autoimmune condition or a dermatitis or some kind of mucosal inflammation that doesn't have any, that estrogen is not going to help with. So if you are not getting better, I would say within 3 months of treatment with vaginal estrogen taken as directed, you need to go back to the gynecologist who knows something about this and maybe have a biopsy or, do some more testing to see this may not be actually GSM.
Thank you. For a woman who is 66 and was not supported for HRT in 2002, now I see that was a huge mistake. She says, I want to now try hormones. Can I? I love this question.
So it's a more nuanced discussion, and this is definitely not a one size fits all. You absolutely can have vaginal estrogen. We can have it for our entire lives. It is one of the safest medications on the market. There is no systemic absorption that has been able to be detected in multiple studies. It is safe, 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 even with breast cancer patients. And so you 100% can have vaginal estrogen. The question of systemic estrogen, certainly if you're symptomatic and you need to treat hot flashes, or vasomotor symptoms, it is worth the discussion. In our clinics, we are recommending we're doing a cardiac workup. So we're making sure, because estrogen, at least as far as cardiovascular disease, appears to be better at prevention. Does not cure it does not undo plaque deposition and once those plaques become calcified. And there is some worry that adding estrogen to this kind of pre-existing atherosclerotic disease could potentially make it worse. So for those cases, we are getting calcium cardiac scores and looking at risk factors and having very intense conversations about alternatives to hormone therapy to treat certain symptoms if she has some pre-existing atherosclerotic disease, which we don't want to make worse.
Interesting. Thank you. I am seeing a lot of questions about weight, about fiber, about weight gain, around sort of
The midsection. Yeah. So let's
yeah,
do a little dive into that. So when we talk about belly fat, right? Everybody knows that term and knows what I mean. And belly fat is, in medicine, we refer to it as visceral or intra-abdominal fat. So viscera is Latin for like organs. So it's the fat inside of our abdomen wrapping around our organs, around the liver, around the stomach, around the intestines. The omentum becomes thick, and so that fat is very different than regular fat, than subcutaneous fat. Okay, subcutaneous fat responds to calories. It is our curves. Women cosmetically, I was taught that it was nasty and bad and a sign of poor willpower and just being a horrible person. And it's actually just the way God made us most of the time. And, we should embrace our body diversity. Intra-abdominal fat is something totally different. This fat is typically driven by inflammation, by higher insulin levels, by diabetes. And you can look like me, have a thin outside, and have a tremendous amount of visceral fat. And you have just as much cardiometabolic risk as what you consider to be obese, and which is not a term. It's now, my daughter's in medical school and they call it ABCD, adipose-based chronic disease.
Interesting. Okay.
Yeah, they're getting rid of the term obesity. And, so people who have intra-abdominal fat, regardless of their weight, regardless of their size, are higher risk for hypertension, diabetes, and stroke. So what do we know? What has the studies told us in menopausal women that helps? Women on HRT, starting early, tend to have less visceral fat than women who do not. Okay. Again, not FDA approved. No medical society is recommending it yet for the prevention of cardiometabolic disease.
Right.
That would be my hope in the future. The studies are very clear that it is protective. So, but nutrition is your friend here. So women who have diets high in fiber, average woman is getting about 10 grams of fiber in their diet per day. Women who get 25 or more, and the cognitive benefits seem to max out around 32 to 35 for most women on average. So we need more fiber in our diets. And the foods rich in fiber are always your default. So beans, legumes, berries, seeds, nuts, vegetables that crunch are going to have your higher levels of fiber. I eat an avocado a day in general. I love them, thank God. Some people can't stand them, but for me, it's like I can get a third of my fiber if I just eat that avocado every day. Now, full disclosure, I do sell some nutritional supplements. Fiber is one of them, but that should not be your main source of fiber. It really should come from food, because these foods rich in fiber are rich in a whole lot of other things that are super healthy too, and decrease your risk of chronic disease. So, anthocyanins and vitamins and minerals and nutrients, so foods rich in fiber are like a powerhouse and are your friend. So that's one thing. And Rachel, I have lost my train of thought. Where did we even start on this? You had a question about fiber?
No, you
visceral fat. Okay, what else can you do? Watching added sugars. So sugars, sugar is sugar. However, sugar is made by God. in foods, not by Nestle, or I'm not trying to pick on one, processed sugars, foods
Right,
added in cooking
right.
and processing
Refined, right, yep.
are not your friend, refined
Okay.
sugars. So, because the foods rich in natural sugar, like an apple, are also rich in fiber, are also rich in, and things that are rich in fiber will slow down the absorption of that sugar. So your insulin levels don't bump as high. So, dates don't raise your blood sugar that much, and they're packed with natural sugars. So, because they're also rich in fiber. So, when you limit the added sugars in cooking, processing, and alcohol to less than 25 grams a day, women tend to have lower visceral fat levels and lower risk of cardiometabolic disease. Exercise, any type. I'm so sick of seeing all these exercise physiologists battling out amongst their things about HIIT or this or that. You should be
Right,
doing.
right,
Look,
right.
I'm not here to get an athlete 1% healthier. That is not my job. My job is to meet a woman where she is. And
Yeah.
listen, if she's on the couch, we got to get her walking. If she's walking, she should put on a weighted vest. If she's doing that, then we need to add in some weight training. Okay, you should be throwing in, the nutritionists that I like to follow are like 150 minutes a week of your cardio is what you need. You should throw some sprints in there too. Do something that's going to get your heart rate up for a few minutes, a couple of times a day. You don't have to do a lot. You should have some kind of hit in there, but most of your training should be somewhere in zone 2. And you should be doing some kind of resistance training 2 to 3 days a week. But to tell a woman who has no resources, nothing, who can barely function in her life, who's absolutely, that you need to be going to the gym 3 days a week, you need to hire a trainer, you need to be doing HIIT, you need to get a weight vest. We got to meet these people where they are.
Yeah. And I think
And
it's really important to kind of educate and then cut a lot of slack, because there's so much that determines how a person can work out or what a person ends up putting on their plate. So sort of giving them the best information as you do, and then giving them a lot of room and bandwidth to take it it's important. Otherwise, discouragement gets possibly too loud. Dr. Haber, first of all, there's a ton of thank yous, and you're wonderful and you've changed my life. There are lots of questions, yes, about sort of addressing chronic conditions and MHT. And I want to sort of give you a minute to speak about what is an absolute contraindication. There's much fewer than people know.
than people think.
Yes.
Yeah.
And really, when you or any physician talks about sort of the data and the research and safety and efficacy, the truth is that the research post the WHI study is limited, and you and so many of your colleagues, us at Alloy, are working to change that. However, as you mentioned about specifically estrogen being cardioprotective, what's protective to the brain, what's protective to our bones, can you just sort of run through that one more time so that we all understand really?
So
There
first,
is
the absolute
safety, there's
contraindication. So,
yeah.
if you have a tumor, malignant or not, that is being fed by one of the sex hormones, you should not be taking extra sex hormones to feed the tumor, right? And so that could be breast cancer, that could be an ovarian cancer, so while you're being treated and evaluated, now, does it mean if you've ever had a history of breast cancer or ever had a history of a gynecologic cancer, you're never going to be able to take HRT? That is a nuanced conversation. There are breast cancer survivors who have been properly treated, gone through all the therapy, and are now getting benefit because they've got to live the rest of their lives, with worries of osteoporosis and heart disease and whatever. So it's not an absolute no, but you need to see someone who knows what they're doing, who can review the data with you, and then help you make an informed decision as to what you think you would like to do. If you have severe liver disease, so estrogen is metabolized and kind of cleared through the liver. So and I'm not talking about mild fatty liver disease, I mean severe liver disease. That's a tough one because we're not going to metabolize estrogen like a healthy liver would do it. And so that is probably something for most patients, severe liver disease is going to be a contraindication. Okay. Because of the way that we metabolize estrogen, you're not going to be able to metabolize it properly. if you have active, an active blood clot that you're being worked up for, it is considered to be a contraindication at this time. Once you're done with treatment and they figured out why this happened,
Right.
we know that non-oral forms of estrogen, including vaginal estrogen and transdermal estrogen, do not increase the clotting factors in the liver and will not increase your clotting risk over baseline. Okay. You are still at increased risk because of your history, and whatever caused this to happen, but adding in a non-oral form of estrogen, oral, yes, we see a bump in our clotting factors. So again, there's a few others, an HRT, menopause trained provider can go over the
Yes.
absolute contraindications with you. Stroke, if you're actively being evaluated for, cerebral CVA or, sorry, medical terms, some kind of
No,
a stroke,
it's okay.
right?
This is helpful, actually, I think, for us to hear, because
And
you
and
must,
here's the big one.
yeah,
If
yeah, go
you
ahead.
have unexplained vaginal bleeding,
Yes.
okay, and you have not gone to the gynecologist and been worked up with an ultrasound plus or minus biopsy, do not start hormone therapy. That could be a tumor that is being fed by estrogen or progesterone or whatever, and we need to get that evaluated. So, undiagnosed vaginal bleeding that is abnormal for you needs to be evaluated before considering hormone therapy.
Thank you for that. And please understand, for anybody who's listening, if you have spoken to a physician, you will know if you have these things, certainly, but get evaluated. And until then, if you are suffering, you want to understand the risk benefit, sort of what you are coming up against and what you are really, how you're really able to be helped, which in most cases is with, addressing all of the silos, the nutrition, the exercise, so on. And then of course, MHT. Could you speak about the difference between the birth control pill and MHT?
Mm-hmm.
Many women
Are
are
confused.
offered a pill. Yeah. And it gets confusing. You may feel like,
Mm-hmm.
what is it with the pill?
So when we talk about, let's talk about why birth control pills were developed. They were developed, they're only FDA approved. When we talk about using things off label, birth control pills is one
Yeah.
of those things.
Yeah.
The only thing it is FDA approved for is contraception.
Right.
Okay,
And
so
some of
birth
the
control
things it's
pills.
used off label
Oh my
for.
God, acne,
Yes.
PCOS,
Yeah.
I used it, cramps. We use it all the time for dysmenorrhea, for heavy bleeding. It does so many things for patients. But that's all off label. So like going off label is not to be demonized. It's just, I can't control what the FDA is going to approve things for, but I know from my teachings and what's recommended by medical societies that they are recommending this medication for this, with a caveat to tell the patient this is off label, but here we go.
Right.
So birth control pills developed to stop people from being pregnant when they don't want to be. And that requires stopping ovulation. No egg coming out, no baby. So you give your body enough estrogen to tell the hypothalamus, to tell the brain, we don't need the ovary to create any estrogen. We have enough on board. Okay. Menopause hormone therapy was developed to stop a hot flash and for nothing else. Okay. That's why they made it. Turns out the dose needed to stop ovulation is 3 to 4 times higher in general than the dose needed for hot flashes for most women. Okay, when we look at serum levels of estrogen. And so dose is the biggest difference between birth control and menopause hormone therapy. Much higher, 3 to 4-ish times higher than the average birth control pill versus what is in the average menopause hormone therapy dosages as far as estradiol goes. Okay, or estrogen or ethinyl estradiol is what is in, which is synthetic, is in most birth control pills. The second thing is formulation. So the most birth control pills, like I said, are using synthetic estrogens and progestogens. They're cheap, they're easy to create. Now there's a couple of new ones coming out on the market that are bioidentical. Super excited about those. But for menopause hormone therapy, most people in my world that I choose to surround myself with are using what we call bioidentical, which is really a marketing term, but we are trying to give the patients back what the ovaries made as close as possible. And that is going to be plain estradiol and plain progesterone and plain testosterone. Now, not everybody tolerates these doses. We have alternative options available in the form of Premarin or in the form of the different progestogens. And it's great to have options, but for most women, we're gonna give them estradiol and progesterone to mimic the ovary, like it's an artificial ovary. So
Right. Okay.
give them back enough to, now the doses were formulated to stop estrogen. What we don't know is what was the best dose for cardiovascular disease prevention. And so the studies that looked at that only said, is she on it or not? And most of those people were on Premarin or Prempra.
Right. And so important just to kind of make absolutely clear that the pill is to suppress something. The hormones are actually much, much higher than they are in
MH2.
HT. Right, right,
Now,
right.
if a perimenopausal patient comes in and she needs contraception as
Right.
well as treatment of her perimenopause, we may have a discussion based around, as this happened yesterday. We offered her a very low dose, birth control pill, because she needed things outside of just treatment of perimenopause,
Okay. Thank
like
you.
contraception.
Right.
So you can
Mega
still get pregnant
important.
in perimenopause.
Yes, thank
So
you for saying that. If you can still get pregnant in perimenopause, if you are getting a period and you have not gone one full year, you are without a period, you are considered perimenopausal and therefore able to get pregnant. Dr. Haber, what are sort of like three lifestyle changes women can make right now to improve their menopause transition?
um, make sure you're getting enough fiber in your diet.
Okay.
I think that's critical, and fight to make that fiber from food. You know, Supplements are meant to supplement a healthy diet. They do not take the place of good nutrition. I want to be clear. And as someone who sells supplements, and you hear me say this over and over again, my wish is for no one to need a supplement, but
Sure.
modern life just gets in the way, and supplements can be helpful, but it's not like you can just fill your belly with processed foods all day and then take a bucket of supplements and think that you're
No.
negating something. And it's just not how it works.
Sure.
Supplements really should supplement a good, healthy diet based in whole foods and not processed foods. So, limit your processed foods. I think limiting your alcohol intake as much as possible would really
Yes.
probably go a long way for your cognition, for your sleep, for so many things. The more we're learning about alcohol, the worse it's getting. And so, drinking less, focusing on drinking less, focusing on eating more protein, eating more fiber. It's such a better mindset than restriction, right? Than counting
Absolutely.
calories and being so focused on calories. Nutrition over calories, strong over skinny. Pick up some weight. You want to start building a body that is going to support you in your old age, and it starts now. And we were so focused, I was part of the problem, so focused on being thin, because thin was healthy. And, instead of building a kick-ass body with muscle and bone strength, we were chipping away at it by trying to be thin our whole lives. Right. And I was part of the problem. And I've really done a 180 here. And since Galveston Diet started in 2016, we've completely changed our song about weight loss. It's more about health gain and eating more, not less.
Strength over skinny.
Yeah. So really, and it's so much of a more fun way to live.
Yes.
Trying to eat more instead of less.
Yes. Dr. Haber, someone asks, there doesn't seem to be a lot of talk about MHT for people with PCOS or NCAH. Mm-hmm. Is anything different for someone with these conditions?
Well, it's just a lot harder to diagnose. PCOS is a chronic anovulatory or oligoovulatory condition, which is exactly what happens in perimenopause. They just have different causes. And so, and then like for me, I was a thin PCOS patient my whole life. I had insulin resistance, had to do fertility to get pregnant. And I was masking perimenopause because I was on birth control pills to treat my PCOS. So I kind of missed a lot of that was going on.
Yeah.
And so I'm just like, you have to be your own best advocate, especially with endometriosis, PCOS. And so it's a lot harder to diagnose and it might get missed. And, I talk about this somewhat in the book, and I'm writing a new book right now on perimenopause, and we're going to cover this in detail.
Terrific. Thank you. You did speak about sort of the oral estrogen, why it might be contraindicated for somebody, but can you just sort of tick off the ways of taking
Yeah.
MAT, the
So when
modality.
we have systemic, meaning we're treating everything, the brain, the bones, the gut, so we're getting it into the bloodstream, right? So we have, or the way I like to think about it is oral and non-oral. So oral pill, that's easy to remember, right? Non-oral could be a gel, a cream, a spray, a patch, a ring. We have multiple options for non-oral forms. A pellet, even, it's not my favorite, but pellets are a way to get medicine in your body. And so the FDA approved options for non-oral are the Eva Mist, the estrogen gel. There's a couple of brands out there, the patches, which could be combined with the progestin, like the combi patch, or the plain estradiol patches. And the ring. There's two rings. One is for GSM, genital urinary syndrome of menopause, and the other is a much stronger dose that actually treats GSM and gets into the bloodstream to go systemic.
Okay, great. Thank you. I saw a question about testing. Can you clarify this? Getting tested in perimenopause. Do we do this?
So
Not do this?
remember, it's perimenopause is a zone of chaos. I
Mhm.
wish, Rachel, that we had this kick-ass bomb-proof test to be like, yep, you're in stage 1 of perimenopause, whatever that would look
Right.
like. But because it is that zone of chaos and it is completely unpredictable, we don't, for a one-time blood test, urine or saliva, they are not clinically relevant. And so we make the diagnosis of perimenopause by listening to the patient, believing her, and ruling out a whole bunch of other stuff. And so a lot of things look like perimenopause: PCOS, autoimmune disease, anemia. You remember when estrogen goes haywire and walks out the
Right.
door, all these organ systems are affected. Where I had hot flashes and joint pain, you may have hair loss and loss of libido, or whatever combination. We've identified over 70 symptoms
Yeah.
that can be affected when estrogen starts, not acting normal, and progesterone and testosterone. And so, you know, it's you have to listen to the patient. You have to know what you're doing. You have to believe her. You know, it may, and you just realize that if you are traditionally trained, you probably have not gotten much clinically relevant information on
That actually leads me. I'm seeing several questions where people are talking about sort of adverse effects to
that.
either estradiol or progesterone. And I'm thinking about a woman who either connects with one of our menopause specialists or walks into your clinic, and how do they make the best of that time and start to understand, I'm not feeling well, I think it might be the
Mm-hmm.
estrogen. So I guess it's a two-pronged question: is how do you as the practitioner address when a woman says, I'm having these adverse side effects?
Yeah.
That's number one. And number
So,
two, how can she best communicate to a practitioner?
so on our website, we have the menopause empowerment guide. The easiest way to find it is on my Instagram. You go to the link in bio on TikTok or Instagram, and it's there. It's free. Put in your email. We ship it to you. It's like 14 pages. Okay. A PDF to download. But we have tons of links in there, like how to talk to your doctor about something difficult, things to look for, questions to ask, lab tests to ask for, so that you can go in as empowered as possible. But when I have a patient who's not doing well on her HRT, like maybe her hot flashes went away, but she's having recurrent vaginal bleeding, right? Which is 50% of women starting hormone therapy will have unscheduled vaginal bleeding. So I always warn them that this might happen. It does tend to get better over time, but that's why we have different formulations. That's why the one size fits all doesn't work for everyone. So like for a patient we've tried everything, we've lowered the estrogen, we've upped the progesterone, and she's still bleeding. We've gotten the ultrasound, she's had a biopsy, whatever she needs, and there's nothing there, right? And she's still bleeding, and it's just frustrating her to all get out. Duovi is a great option for them.
Mhm.
Duovi has beta-doxepine. Beta-doxepine binds and downregulates estrogen receptors in the breast and uterus. So the breast tenderness that won't go away. These patients do great on those particular, it's expensive. It's not covered first
Yeah.
tier for most people on insurance. But for those patients, this could be a great option. I love having options for our patients because not everybody's going to respond the same way. About
Yeah, and
5 minutes.
I know, I'm so aware. And I think that the point that menopause care is nuanced care is what I
Mm-hmm.
really wanting people to understand and take away. We've got 5 more minutes with Dr. Haver. We just got off of the very first Perimenopause Awareness Month in September. This is Menopause Awareness Month. What would you say to younger women, those who you're a mom of daughters who may not be thinking necessarily about menopause yet? How can they prepare themselves both mentally and physically for this?
You know, there's so many great books out there right now. You know, Jessica Shepard just wrote Generation M. Tamsin Fadal's book's coming out. Naomi Watts' book is coming out.
Dr.
The New
Sharon,
Menopause. You know, Jen Gunter wrote Menopause Manifesto, which was a great book. So, you know, there are a lot of resources out there. Educate yourself.
yeah,
Educate yourself. You may know more than your healthcare provider, sadly, and it's not their fault. They weren't taught. And
yeah,
so you have got to realize that you must advocate for yourself. Now, those of us, you know, the big heads at Ally, we are fighting for you in the background. You don't know all the legislation we're trying to get pushed forward, all the, you know, going to the medical society, speaking. I just spoke at the American College of OB-GYN and just said, we are not taking care of these women past, you know, in a way that is clinically relevant, much past reproduction. And, you know, I don't think it should be dumped in all of women's health after having a baby should be dumped in the lap of the OB-GYN. You know, I think it should be all doctors. All of us should, in every specialty who touches a female should know this stuff. So that's, you know, what we're fighting for. But until it's going to take a generation probably for all that gets, you know, my daughter in medical school is like, we got it, mom. We're not going to let this happen. I'm like, yeah, but there's a whole lot of ladies out there who need help. Right now.
Right.
You're not getting out of training.
Shortchanged on the back end and really kind of still muscling through now.
Yeah. So it's, you know, in my clinic, when this is what I want to leave you with, you know, in my clinic, when the patients come, we put out the menopause fire, right? We take care of the hot flashes, the night sweats, you know, the stuff that is not allowing them to function to their fullest. And then we start plotting the course for the next 30 years.
Right.
How's your mom? If your mom is 95, your grandma's 95, look at the women in your family to the younger patients. How are they aging? What is your future looking like? Because so much misinformation and this relentless pursuit of thinness, you know, has led to frail older women who can't take care of themselves. You know, we have this explosion of frailty, of dementia, you know, three to four times higher than in their dads. And so, but if your mom is 90 and she is cooking and cleaning and living her best life, I mean, yeah, she may have a walker or need some help, but like she is absolutely thriving. We want to do what she's doing.
Right.
But if she's not, let's look at your nutrition. Let's look at your movement. Let's start building that body so that you can thrive for the next 30, 40 years.
Don't fear hormones, don't fear estrogen, certainly. And all of those other pieces matter anyway, all the time. Thank you so much, Dr. Haver, for all of your efforts towards improving women's health. Thank you for this conversation. I always love speaking with you and seeing your face and learning from you. Thank you to everyone who was here today for your thoughtful questions that really do help to further educate all of us. I just want to remind you one last time to take advantage of today's code HAVER20 on myalloy.com and head over to our YouTube channel. Subscribe for more, and we will see you all again soon. Thank you so much. Bye, everybody.